Hi, my name is Jo Gibson and I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK and also a consultant in private practice. So tonight I was going to have a little bit of a change in that we've been doing lots of talking about some interesting case studies, things that you might not see so commonly in your shoulder practice. But tonight I just thought I'd have a little chat about a rehab dilemma, really in terms of if there's some specific exercises that potentially give us best value or whether actually nothing has any superiority. And why did I decide to talk about this? Well, a guy that I got asked to review in my private practice who'd actually had an 18-month history of right shoulder pain. When he told me his history, it sounded very much like he'd had a straightforward supraspinatus tendinopathy, very definite cause and effect. He'd done some more loading in the gym. His job was essentially very desk-based, but essentially he liked going to the gym, he liked going CrossFit. They'd got somebody new doing one of the circuits. He'd got a bit carried away and done more classes than usual in 1 week and had got pain. Now, it sounded like he'd had great physio. His physio had given him lots of great advice in terms of obviously trying to address the inactivity during the day as part of his work, talked to him about load management, and in giving him what sounded like a really sensible exercise program. Now, clearly, when I meet somebody who's already seen a couple of different practitioners, this guy had also gone for sports massages and some acupuncture, and had obviously, after not getting better with the first physiotherapist, obviously done a little bit of treatment shopping, but somebody had recommended to come and see me. And so essentially it was, okay, what are we going to do now? Now, I really tonight want to talk specifically about the potential role of eccentric exercise in somebody like this and whether it gives us any additional benefit, particularly in a population with tendinopathy. But clearly, before I do that, when I meet somebody like this, it's really important that I reinvest in hearing their story. We're going to talk about a very specific approach to exercise and whether it does have any particular role. And hi to everybody who's saying hello. Fabulous to have you here. I promise I'll come back to the comments, but I really appreciate you saying hello, and it's great to have you all here. But so when I have somebody like this and I'm sitting down and I'm kind of hearing a long story where perhaps somebody sounds like they've done the exercises and they've bought in, it's always important to go right back to that story. So in terms of problem solving, as ever, I look at this within that person-centered or biopsychosocial perspective, and there's some really crucial things. And the first question I always ask them is, what's your understanding of the problem that you've got? He said to me, well, I was told I had rotator cuff tendinopathy. And I said, well, what does that mean to you? And he says, well, I did a bit too much. That was the tendon trying to get back to health, but it just seems to have got stuck and it's got to a point where it's not improving. So this guy's got a pretty good understanding. So I then ask him if he's been doing the exercises or how long he did the exercises for. And he tells me that originally he did the exercises for 6 weeks and then got a little bit despondent because things weren't working. He was doing 5 exercises at the time. It sounded like some scapular work, some through range cuff work, some external rotation. So, some important things that we know to be included. But again, he said he felt the exercises didn't fit into his daily routine. And because he wasn't seeing any effect after doing them for a 6-week period, he got very despondent. So then I said to him, well, what did the physio say in terms of how long this was likely to take to get better? And he said I should expect a significant improvement within 4 to 6 weeks. So there's some clear things that I need to unravel there. There's a couple of things when we look at exercise adherence, and again, we could argue about whether we should be using that term because exercise is always a negotiation with our patients in terms of what fits into their life. But the key thing with this guy, the exercise, he obviously had too many to fit into whatever his schedule was. He'd lost faith because he'd obviously been given potentially unrealistic expectations, because if you look at the literature, it's pretty clear that in somebody with no significant negative prognostic factors, on average it will take people 12 weeks to get back to where they want to be. Now, when we say where they want to be, even in that case, you're still looking at probably an 80% improvement with some residual symptomology. So setting those realistic expectations from the outset is really important. Now, and I know that we do have patients who do respond far more quickly, but it's kind of better to under-promise and over-deliver, and that's where the evidence really helps us in terms of underpinning those potential timescales. Now, the good thing with this guy is even though he's got a static job, the fact is that we know that because he's exercising regularly, that's a good prognostic factor. So I'm going to check his understanding, check what the explanation he'd had for him, and find out where things had gone wrong. So clearly those expectations were a little bit off kilter, but also importantly to check that he's still got a belief in physiotherapy. And again, it's eliciting patients' expectations is such a simple thing, but if we don't do it, then again we set ourselves up a barrier to somebody getting better. What do you think needs to happen to get you better? I think I need to do some strengthening to get the tendon healthy again, or I think I need an injection. We need to know those things so that when we educate our patients, we put a positive reframing on those things so we get them back on board in terms of their journey. Now, again, I talked about looking at things within a kind of biopsychosocial model or a person-centered model, if you like. But the key thing, again, is not always just looking at load in terms of he seemed to have this clear cause and effect in terms of what happened at the gym, but we also know the importance of looking at load in those other domains. So if there's any key life stressors, any changes, any problems going on at home, and again, that's not me being a psychologist, but it's just appreciating the wider picture in terms of those things that can affect tissue health and pain sensitivity. Now, this guy, the key things seem to be, one, he had unrealistic expectations. He got a pretty positive frame, and clearly he hadn't been looking for an orthopedic fix. He said he didn't want surgery. He said he'd had an x-ray from his GP when he hadn't got better after 6 months, and that was absolutely fine. He wasn't somebody that was pursuing a scan, so I was kind of in a fairly strong position. Now, again, in terms of those lifestyle factors, the fact that he's sitting all day and then kind of doing a boom and bust in terms of the exercise is also an important thing to ask, and also how he moderated the load he was doing in that recovery. So some very simple things can really set us up to fail if we don't negotiate them at the outset. So I might say you might need to back off at the gym, but if we don't discuss the specifics of that, what he interprets and I interpret might be different. I always remember having a lady who was a stunt lady, so she got employed on films to do all sorts of amazing things, had a really nasty tendinopathy, very, very irritable. And I thought we had discussed how she was going to modulate her training. And she came back to see me still in lots of pain. Things weren't really settling. But when I asked her, what was she doing in terms of training? She said, I'm only doing 7 hours instead of 8. So that poor tendon was still getting quite a hard time. Now, these might seem like such simple things, but when I meet somebody like this guy, it's really important to go right back to the beginning and hear all those things. So what does he understand about what he's been told? And importantly, what does that mean to him? What are his expectations? Has he still got a positive view about physiotherapy? Even if he hasn't, that just helps me in terms of setting the narrative when I educate him at the end of the session. Investigating those other lifestyle things, making sure there's no kind of negative information coming from anybody else. But also importantly, the other thing is to hear that story. Now, again, with this guy, it was quite straightforward. He'd gone to the gym, he'd done more than usual, he'd woken up with pain. He'd got fairly localised anterior lateral shoulder pain. It was horrible on quick movements. It was not very nice at end range and above 90 degrees. Typical pattern that if he did stuff, it got a little bit easier, but then it would be horrid the next day if he overdid it again. And he's just got into this horrid cycle where things weren't changing. Now, interestingly, what do I need to think about? Well, the first thing is, did he do the exercises for long enough? Remember, 12 weeks. And when we look at what matters in terms of what seems to give us successful outcomes, it's having 1 to 3 exercises, and this is in a non-sporting, non-elite population. So when we just look at our general population, 1 to 3 exercises done for a minimum of up to 12 weeks. Now, that's interesting because a lot of exercise interventions only look at a 6-week intervention. However, has he done them long enough? Has he done them often enough? And essentially, have I pushed it enough? So obviously I'm meeting this guy thinking, what can I add to the mix? Now, I kind of have my favourites in terms of through range, setting foundations, looking at torque production role of the cuff. But importantly, for somebody like this who goes back to the gym, what I really want to do is get him back to doing what he wants to do as quickly as possible. Now, interestingly, when I meet him, he's still got a bit of a block to abduction. So he's kind of, the tendon still seems to be quite irritable. But when you ask him what he's doing, he's still going to the gym. Now, that's a good thing because he's keeping some level of activity. But it seems to be that he's not been able to get to a situation where the tendon has settled down. So the purpose of tonight, having kind of considered the story, the fact that he probably didn't do it long enough the first time, this guy has already done many of the exercises that I would generally use and then progress. And of course, there's lots of variations, but the bottom line is what I want to do is try and influence that local system. He's a happy guy in a good relationship, likes his job. He's breaking up his work at his desk during the day. He's going for a walk at lunchtime. He's really on board with all the lifestyle stuff and keeping healthy, but he's getting very fed up about this irritable tendon. So what's the option? He's 18 months down the line. So the question I wanted us to really ask tonight was, has eccentric exercise got any additional value in this sort of situation? Now, interestingly, there's been lots of, 1, 2, 3, 4, 5, probably about 8, 9 different papers that have looked specifically at the role of eccentric exercise. The huge problem is that what they've done is generally add it in to other things. So the least interventions in one study was a paper by Shakinas et al. In 2017, where they looked at eccentric external rotation with with a scapular retraction exercise and a posterior shoulder stretch. That was the minimal interventions of these eccentric studies. Most of them do combinations of full cans as well as external rotation with other exercises for the scapula. Now, the reason I thought I'd bring this up and I thought it would be interesting, those of you who work in the lower quadrant will be very aware of eccentrics in things like Achilles tendon and patella tendon. I think in the patella tendon, they're going out of favour a little bit. But when we look at the Achilles tendon, Alfredson, who was one of the big researchers at the very beginning, actually did a pilot study looking at using the kind of full cans position, doing it eccentrically, so that lengthening phase, so if you like, assisted them up into abduction and then controlled that eccentric phase with supraspinatus. Now, they only had 9 patients in that pilot group, but interestingly, 5 out of the 9 patients, these were all patients who'd had symptoms for 41 months on average, so they real persistent pain patients, and 5 out of the 9 had a really good effect and didn't have surgery. And essentially, when they were followed up at a year, they still hadn't opted to have surgery. Now, interestingly, we see a very similar thing in some research done by Teresa Holmgren and one of her colleagues, Hallgren et al., who did a longer term follow-up, and they showed a very similar thing. They took a group of patients that were on a waiting list, having failed usual physiotherapy, so cuff, scapula, all that kind of stuff, hadn't got better, and then they added in eccentric exercise. Now, in this study, they said they could work up to 5 out of 10 in terms of pain provocation. They didn't talk about a 24-hour pattern, but as long as the pain didn't go over 5 out of 10, then that was acceptable within this study. Now, the key thing with this, and one of the big problems with interventions looking at eccentric exercise, is they did other exercises as well. They did scapular exercises, general cuff exercises, some stretching, and then added in these eccentric exercises on top, working into pain. Now, the interesting thing was when you looked at the 2 different groups, the groups who didn't do the eccentric intervention, 63% went on to have surgery. In the group that did eccentric exercise, actually only 20% went on to have the surgery. So it did suggest that in a chronic population, eccentric exercise might have some more additional value. And there's absolutely no doubt that when you break down the studies into those who've had symptoms for a longer period of time, then adding in eccentric exercise seems to have some benefit. The issue is that if we look at the comparison of concentric and eccentric in everybody with shoulder pain from the outset, it doesn't seem to give any additional benefit. Mealy's Meinhout did a lovely paper in 2017, again showed no real difference in terms of strength, pain and function comparing concentric and eccentric programs, but essentially did show that those who'd done the eccentric program had slightly better strength in isometric abduction. Now, I guess you have to ask yourself, a lot again of the studies that have looked at eccentrics have looked at abduction, long lever arm, which is pretty hard going for a tendon that's already unhappy. So again, when we look at shoulder pain generally, most of the evidence supports dysfunction in external rotation or loss of force production in external rotation. And that's why it's guided or informed a lot of exercise choices when we go into Google and look at common approaches to shoulder pain. So the other thing that's really interesting is all these studies generally did the exercises a minimum of 5 times a week, and actually in most of the studies every day of the week, and in some studies twice a day. Now that's really interesting when we look at the proposed mechanisms of eccentric exercise. If you look at studies looking at normal populations and rat-based studies, they show pretty clearly that we get increased collagen synthesis, and eccentric exercise seems to have some additional benefits in terms of neuroactivation, or if you like, we get these force fluctuations as a result of eccentric exercise that seem to have a beneficial effect on the intrinsic health of the tendon. We don't see macroscopic change, but we do see a reduction in fluid content, and we do see an impact on collagen synthesis. But the thing is, those things need time to respond, and none of the studies that have actually looked at eccentric exercise arguably have given any time for the tendon to respond. What is interesting is that studies have looked at the comparison of working into pain or not working into pain, and actually what they've shown really clearly is it doesn't matter. There's no preferential effect of working into pain, and the dosage in all these studies was anywhere between 3 sets of 8 and 3 sets of 15, generally getting people to progress as they felt able. So if you like, patients as it started to feel easy would increase the resistance themselves, so very much their own rated perceived exertion guided that increase in resistance. And there was no evidence of any benefit of actually working somebody for 4 weeks and then imposing a progression and working into pain, which is quite an important message. So for me, why would I think of using it in this gentleman? Well, as I say, the problem is the evidence in terms of that additional benefit in terms of reducing fluid in the tendon is mainly done in normal populations or in a rat population, similarly with that collagen synthesis. But the evidence does seem to suggest that we get more of a specific effect on that intrinsic tendon. So if I've got somebody who's had symptoms for that period of time, so remember this guy's had symptoms for 18 months, I want to choose an exercise intervention that's going to give me the best bang for my buck. Now, how can we take what we know from eccentrics, and remember we talked about some mechanisms, there's some other postulated mechanisms like sarcomerogenesis, i.e. we get a lengthening in the muscle tissue which changes the length tension relationship in terms of the tendon and the muscle. Very theoretical. We haven't got masses of evidence to support that. But again, the sarcomerogenesis is something that's now being used as a basis for using eccentrics in stiff shoulders. However, in this guy, I want the maximum bang for my buck. What's the other thing that we know about people who've had symptoms for a long period of time? Well, we have evidence to suggest that we get changes in the cortex. So that would suggest if I'm going to choose an exercise intervention, I want it to be as sensory rich as possible or affect those cortical pathways. And interestingly, there is some evidence to suggest that eccentric exercise is superior to concentric in terms of its proprioceptive effects, but importantly, those cortical pathways. So basically, that gives you the evidence is really clear. Well, no, it's not really clear. The evidence would suggest that using eccentric exercise in a first-time shoulder pain has no evidence of superiority than concentric. And the bottom line with shoulder pain is get them doing something that's meaningful, that's progressive, and for long enough. This guy's not getting where he wants to be. I want him to do something that feels specific because he's very tuned into this tendon, but something that might give me additional value to what he's done so far. So essentially, I give him eccentrics, but I get him to do them with the weight of the arm supported. Why? Because that makes it as much about the rotator cuff as I possibly can. I have an exercise that I really like where I basically lie patients down on the floor. They have their arm out in abduction, just supported on a towel, so their elbows slightly in front of their shoulder. And then they have a big TheraBand loop or one of the resistance bands you can get at the gym. They put that around their foot and they have their arm, as I say, at 90 degrees. Why? Because again, that's the position we maximally isolate that torque production role of the cuff. If I really want to target the tendon, that's the position that gives me best value. And remember, external rotation is as much about supraspinatus as it is about the posterior cuff. cuff. So the great thing then is with tension off, I get them to go into full external rotation, straighten their leg out, and then control that eccentric phase as slowly as they can. Again, we seem to have some tentative evidence in terms of the added cortical benefits of doing that with a metronome to get that time under tension. So I try and get them to control it for a minimum of a count of 8 through that range, using the metronome to type that, and as I say, increase those cortical aspects. So essentially, I sent this guy away just doing a nice through range warm up to get everything doing its job, just short lever elevation. In the clinic, from a symptom modification point of view, that changed his end range pain. So that was his warm up, let's get everything doing its job. And then that eccentric exercise. So I only gave him 2 exercises, but I gave him very clear guidance how to progress. I didn't want it to increase his pain because that clearly had been an issue to him. And of course, I've got to educate him about that. If I meet people early in their experience with tendinopathy, I'm all about, that pain is your tendon trying to get back to normal health when it's very localized and we've had that clear loading effect. But basically with this guy, he went away. I said, if you wake up the next day and it's more painful and it's stiff, you've probably done a little bit too much, so back off the next day. But the other thing that I did do, which isn't replicated in any of the studies that are out there at the moment, is I only got him to do it 3 times a week, because essentially I wanted that tendon to have time to respond. If we're saying we get collagen synthesis, we know that peaks anywhere between 24 and 72 hours after we've done that very specific loading. So if I'm going to get the maximal intrinsic effects on that tendon, it makes sense to give that tendon time to respond. So he just did Monday, Wednesday, Friday. Psychologically, he got the weekend off. And then we talked about what he could do in the gym so that he was still getting that social interaction with his friends. We just kept stuff below 90 degrees so he could give the exercises a really good go. Now, this guy came back to see me. At 2 weeks, everything was going well, really happy. Came back at 4 weeks and he was absolutely just dying to get back in the gym because he felt so much better. Now, did the Eccentrics make that difference? Was it that I just reframed it and said you'd done all the right things but needed more time? Was it that I let him get back to the gym in terms of I concentrated on the can do rather than the can't do? I listened to the things that mattered. I'm sure my communication was part of it. And, I'm sure many of you have heard me say communication is our superpower in terms of making things really resonate with the patient's why and understanding the things that potentially have been a block in the past. However, for me, really what I wanted to talk about tonight was just to share with you, I'm very honest of the limitations in the research about eccentrics, but I do think that the trend in the shoulder population, particularly in terms of external rotation eccentrics rather than long lever abduction eccentrics, is that in patients with persistent symptoms who haven't responded to any other interventions, they do seem to have some additional benefit. And clearly, if you're seeing somebody who's done all the standard stuff and hasn't got better, it's really lovely to have something else in your toolbox when you have that tendinopathy group. And remember, this guy had a really consistent history that really fitted in with that. So of course, there's no substitute for hearing the story right from the outset, and remember all those things I talked about, going back to our detective work and making sure he's got a good understanding, a positive framework for his recovery, that he did everything for long enough, which clearly he didn't, why he's treatment shopping, all those other potential stresses in that psychosocial domain. And of course, I would invest in that. But what I really wanted to share with you tonight is the potential role of eccentrics. Now, there's some interesting research actually looking at the use of eccentrics in acute shoulder pain. And very occasionally when I have somebody with a long-headed biceps tendinopathy that, again, or a supraspinatus that, again, we're just struggling to break that cycle with some of the other things that I use, again, eccentrics done at low level do seem to have some role. How do I rationalize that? Probably because of that change in fluid content, and maybe because of the desensitization effect, just changing pain sensitivity in the tendon. Again, we have to be very honest that we don't know the mechanisms. But if I apply it to long-headed biceps in that more acute population, I know I've got to get the rest of the cuff doing its job to unload that tendon, because generally long-headed biceps is the victim rather than the culprit. However, to desensitize it and apply those concepts in terms of the effect it's having on that intrinsic tendon, I just get patients to kind of almost in a kind of semi-squat position, holding underneath a table, under something that won't move is generally a good idea. And then they can just do a lovely eccentric extension of long-headed biceps using their body weight. Really simple, but if you're struggling, just something to bear in mind. Now, as I say, the evidence really is more supportive looking at it in that really chronic group, but I know there's some exciting research being done by some authors at the moment trying to work out if it also has a role in some of our acute pain populations. If you are going to trial it in those, use it with caution, and I only use it when other things haven't worked. So guys, I really hope that's given you some useful clinical tips and tricks, and just a really interesting case and something that I do find really useful in my practice, particularly when some of the other things haven't worked. Now, let's have a look at all our comments. So there was a comment. Oh, let me just go up. I've just said I've liked somebody's comment, and I'm trying to actually see what the comments are at the top. I'm so rubbish with this. Oh, here we go. Let's just get onto that again. So I think there's a comment there just asking me about, did they work into pain? In those research studies, essentially, some worked into pain, some didn't. There was no beneficial benefit of working into pain. So I personally don't, because if it's not going to make any difference, why would I? And I just wanted to kind of, get this guy on board. And remember, I know that I've got to kind of challenge his beliefs about pain, but the important thing is that I get him on board and then start to challenge that. Eccentric versus long length isometrics. Oh, Kevin, that's an interesting one. Now, again, if you look at how clinicians have applied these, then a lot of people will actually combine doing isometrics in that lengthened position with eccentrics. But quite honestly, we just don't have research looking at that at the moment. As I'm sure you're aware, isometrics seem to cause all sorts of excitement everywhere. Nothing is a cure-all, but it can all be relevant in our patients. And I think what's important in terms of what you're saying there is the great thing is we vary isometrics in a lengthened position as opposed to a shortened or mid-range position. We will just have different neural effects as well as different effects in terms of the muscle tendon unit. So again, we don't have specific evidence looking at that, but yes, why not? And again, I like the idea of the lengthened position, particularly in somebody who's had long-term symptoms, purely because of those added proprioceptive and cortical effects. Jenny, I missed the start. Who's the presenter? Jenny, my name's Jo Gibson. I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit. And I'm, Marlene's done a lovely job of introducing me. Thank you, Marlene. That was very kind of you. So Nick Emery, any thoughts on isometrics and mechanotransduction? So I think when you look at mechanotransduction, that's why our more kind of things like eccentrics and lengthening and getting that cellular response kind of makes a lot of sense. And I think when you look at this interest in terms of what they call force fluctuations. So when you look at the changes in force during an eccentric contraction, you get this kind of sinusoidal wave as opposed to a concentric where it's much more consistent. And there's some thoughts that's one of the additional benefits of eccentrics. Now, in terms of isometrics are getting really bad press. There's a systematic review just come out by Bonello et al., which includes Ebony Rio, who clearly has published about the efficacy of isometrics in the patellar tendon. The problem is that there is just not a heterogeneous application of dosage, of how much percentage it is of somebody's repetition max, etc. There's quite a lot of evidence by a guy called Norgal looking at the analgesic effect, but essentially that was mainly done in non-painful populations, so basically asymptomatic. So again, can we extrapolate it? What was the other thing I was going to say about isometrics? Jeremy Lewis, Parle et al., that was with Jeremy, did a pilot study comparing isometrics and ice and found they have a comparable effect in terms of analgesia. But it was a pilot study. We haven't had a bigger study looking at that. And in fact, no, they did do a bigger study and it was less convincing. So for me, I'd always rather get patients moving. But if you can't get them moving and you can't get them to do anything else, then isometrics are a reasonable thing to do. There's a cool thing called cross-education, where if you really can't get them to move, you can work the other side hard at about 70% of maximum voluntary contraction. And then you get the same light up of the same cortical pathway and probably an overflow effect as well. So I can send a link to that Benelli thing about isometrics, Kevin. Well worth a read if you're interested in that. Now, where are we now? I think sorry, got all carried away. Let's go down here and see if I can get to the... I'm so rubbish at this. I don't seem to be able to... Somebody's just put about isometrics in the stiff shoulder. Yeah, absolutely. So isometrics in the stiff shoulder, that's really coming back to that sarcomere genesis that I was talking about. So that lengthening effect in the muscle. Basically, that's been used as a way of increasing range in frozen shoulder, because we've had to face the fact that no matter what we do, we can't essentially deform the contracture in the capsule. So we get that contracture in the superior rotator interval and that reactive fibrosis around the rest. There's kind of an increasing interest on the use of eccentrics to try and give us an increase in length via the muscle tissue, which obviously interdigitates with the capsule. Have we got evidence for it? No, we haven't. Most of the evidence has been taken from the lower quadrants, but it's certainly something I use in my practice and find very useful. So I'd use eccentrics of subscap if I'm trying to improve external rotation, but then I'd actively work the posterior cuff into its inner range. We can definitely talk about that on another one, but that's actually in our stiff shoulder webinar that you can still get hold of if you go to clinicaledge.co/shoulder. Jackie, lovely to have you here. Slap tear and eccentric biceps loading. So again, I think the key thing with slap tears and stuff for me is always building foundation. So my focus is always to get the rest of the cuff doing its job first. I always say the cuff, I mean the cuff, the scapula, the shoulder muscles, so that I normalize loading over the long head of biceps, because often poor old biceps gets a hard time because those other things aren't doing a job. However, where eccentric bicep loading can be really, really useful, again, is when you've had somebody who maybe had an original injury so a traumatic slap that actually warrants surgery, and has some bicipital symptoms, often because the biceps has not been on tension for a long period of time, and when they operate it and reattach the superior labrum, biceps can get really grotty and unhappy. And in those situations, eccentrics can have a real role. And again, I rationalize it that it's affecting that intrinsic tendon. Of course, there's no doubt going to be loads of research that tells me lots of other reasons, but that's how I clinically reason it in my head. So in that situation, yes, but I also would say that increasingly in that situation, there's a trend to do a tenodesis rather than actually even try and keep biceps, because when there's been any loss of tension for a long period of time, you end up often going back and doing a tenodesis because biceps doesn't settle down. But in terms of progressive biceps loading, Anne Cools did a really lovely paper looking at that and looking at progressive loading specifically for biceps. So Jackie, I hope that answers that question. Thank you for that. Guys, our half hour's up already. Oh my goodness. I hope I've answered all your questions. Kevin, I'll definitely post you that link to the Bonello paper, because well worth having a look. I think we need more research about the long muscle length isometrics. I don't think that's well represented in the literature. Milo, I hope I answered your question about frozen shoulder. Tina's last question before I leave you to it. How do you know when to integrate the eccentric? So essentially, I would integrate eccentrics if it's relevant to somebody's sport or activity, okay, in terms of what they need to get back to. And if we look at some of our sporting populations, weakness in eccentric external rotation is definitely a factor. That's something, again, we can probably talk about in more detail in a future Facebook Live or podcast. But essentially, the purpose of this case study is the time that I definitely think about them is in somebody who's had persistent symptoms, who sounds like they've got good rehab with a history consistent with tendinopathy, or just persistent shoulder pain. And the other group, as I say, is that acute reactive group, again, where I'm struggling to break that cycle. So it's more those clinical indications or their relevance to a patient's function. So Tina, I hope I've answered that as well. Guys, I feel like we've packed in loads tonight. Thank you so much for your questions, all sorts of great questions. And oh, good, I have answered it. Paul's just sneaking a last question there. Is there normative data for how much force somebody should be able to produce for IR, to estimate cuff function? So, Paul, a very quick test, if you haven't got a handheld dynamometer, is if you lie them in prone with the arm hanging down, in that position, then the relative ratio is meant to be 1-to-1. And the good news is if it's meant to be 1-to-1, from a clinical perspective, you will pick up a significant difference. In terms of manual testing in another position, unfortunately, we can miss up to a kind of 30% deficit without using formal testing. So we have to be a little bit careful. The general ratios that are reported are around 3-to-2 internal rotation to external rotation. But again, what we're seeing with normative data is that actually can vary from sport. So that's more in a normal population. So guys, I am definitely going to go now because my son's cooked my tea and I promised I'd only be half an hour. And as ever, I get all enthused because of your great questions. So thanks so much for joining. I hope you've taken some clinical tips and tricks away as ever, and a kind of synopsis of where I think the evidence is at with eccentric exercise in the shoulder. If you do use it carefully, and I would always say start lighter rather than heavier because it can be incredibly provocative, and give your patients their safety cues so they know that if they wake up the next day and it's sore, not to panic. They probably just did a bit too much and to back off the next time. They've not done damage, they've just loaded that tendon a bit more than it would like to. So see you guys. I hope you'll join us again next Monday. We're going to have another really challenging case study next week, something really unusual in answer to a question I had a few weeks ago. And then the week after, we'll probably get back to something rehabby. So thanks again for joining. If there's any questions I've not managed to answer, I promise I'll look at the Facebook group later and I'll answer that. Sorry, the Facebook page. I'll answer them on there later. Bye for now. And as ever, thank you so much for joining. It's just fabulous to share some shoulder geeking with all of you. Bye for now.